is language. In fact, to me, the most worrying sum is the language. We are so much into, this. I'm not against any of these modern, see, because of this Zoom and things, I'm able to sit in my room and speak to 65, 70. Of course, I would have been very happy to look into the eye and speak to you all, so that my language would be better. I'm staring into a screen, but in my mind, I'm imagining 60, 70 of you all, some maybe half sleeping, it is post lunch, some maybe looking into WhatsApp messages and ticking, doing thumbs up and emoticons, and some may be doing their work, and this is all, but doesn't matter. I can picture all that, because I must confess, sometimes I do all this. So language, how do we assess language? And then visuospatial. So all this becomes a cognitive domain, but slowly and steadily, if we don't think about these areas, find out and push this into our regular practice, we are going to have a whole lot of population, because there is a shift in demographic pattern. We are having our demography in India has become cylindrical now. We are having as much middle-aged as the youth, and the fertility rate has decreased. So birth rate has decreased, but longevity has increased. So say the next 20 years or so, you're going to have a whole lot of elderly, and then you're going to have many of them with cognitive domains, and that is going to take a toll on may not be for a doctor sitting behind with a coat who controls the blood pressure and sugars and does stenting and things like that, but it is going to take a toll on the society. The quality of society living, the society reaction is definitely going to come down. So in plain language, I would like to say that Alzheimer's and other forms of dementia are not inevitable consequences of aging at all. In a proportion of population, actually, I think, I don't know, it may be possible to prevent or delay the development of dementia. Maybe we can modify exposure to common risk factors. So maybe some early diagnosis and intervention can delay the onset of dementia, and it could be beneficial for patients and their carers. And it can, in fact, it can result in loss of cost saving to the elderly. This is what I believe, and I'd say, I think so, So let me go through the slides. One second. Okay. So what happens in an elderly is that cognitive that I told you, there's going to be a decline. Now, I kept talking to you about, let's modify the risk factors. Let's modify the risk factors. So there's a lot of risk factors over here that I have put, some, which mainly you will see that there are two areas. One area goes to the neurologist and one area goes to medical professionals. Now, these are the two areas where cognitive decline picking is not a practice at all. Neither the medical practitioners nor the neurologists may be assessing cognition. Yes, they do. But the whole chunk of population, they go into general medical areas where assessment of cognition decline does not happen. And this is where the risk factor starts off, which will add on. For example, hepatic, renal, thyroid. I'm going to add diabetes here. I'm going to have hypertension over here. That is, let me tell you, in the left block, let me say obstructive sleep apnea, then toxins. These are slowly, they are like cancer cells, which is going to erode into the cognition impairment. Now, these things starts at 40, 45, 50. So picking early, dementia happening early, maybe these risk factors are having more because of the stress that we are undergoing. So a lot of these metabolic and thyroid disorders that are coming up, obstructive sleep apnea, which is going to affect cognition decline. So we correct the obstructive sleep apnea or we correct beta, but we do not assess how much of cognitive decline all this has happened. So these are the risk factors that I'm talking. So when a person has this risk factor, assessment of cognitive decline is a must. Of course, neurology, they look at it, but there are some areas where, as the patient ages, there's going to be lot more cognitive decline, like in normal pressure hydrocephalus. Patient may fall and he may have a small subdural which may not be picked up. Another thing that I have seen is vasculitis. Many have this vasculitis. So all this, we look at disease, but here we do not extend the assessment to cognitive decline. When does the cognitive decline draw attention to us? In the greens down, when they get into severe depression or they get delirium, which may be many causes, possible drug induced, again, we look at it, but we don't pay much attention to it. But we go into the dementia and we put the dementia and we get to understand a patient's life, his cognitive decline, only when it is affecting the carer's quality of life. I want to add here again, this comes to our notice only when it affects the carer's quality of life. It doesn't come to us when it has started affecting the person who is suffering his quality of life, because it is so subtle that it gets missed. So let me go to the next. So when we define delirium depression, delirium is, it's an acute clouding sensorium, fluctuation level of consciousness, and difficult with attention and concentration. Now, depression is low feeling of hopelessness. The patient may complain of memory loss, but then you will say he's depressed, he's old. You're not going to look depression as one of the early markers for memory loss. Delirium depression. Now, there's a big thinking that's coming up is patient, not all elderly, when they come to the hospital, present with delirium. It is some group of elderly. In fact, you should pick when 60s and 50s and early 70s come with delirium with a small shifting sodium concentration. Now, we have elderly who come with sodium concentration of 124, but they don't have any delirium and they don't have any problem with conscious level. But we have patients with 128 delirium, 128 sodium coming with delirium, or a just mild hypoxia, they get pushed into severe delirium. So I think we should watch carefully and see whether delirium, and then follow them up. They can become a cohort for a study, look into their cognitive assessment over a period of time, pick them up whether they are patients who are already gone into cognitive decline and depressed. But what happens is usually delirium is handled by the medical professionals. They come with certain medical issues. So they don't directly come to a psychiatrist. Or to a person who is actually working with memory. So it gets segregated. Patient improves with delirium, but then we really don't go deep into assessing the cognition issues, why this patient got pushed into delirium. Now again, depression or regular onset of depression, maybe it's an early marker for dementia. So and when it comes to depression, when we sit in a medical, we never ask a person, are you depressed? So a medical practitioner will not, we have certain parameters, vital signs check. We will check blood pressure, this. Nobody has a check, goes depth into depression in any patient who are elderly and dealing. So when we talk about dementia, it is end of it. It's a global impairment. It's a global impairment of intellect, memory, personality, but there won't be impairment of consciousness. So again, it may go unnoticed in the early stages, because here patient is having conscious normal. So he's walking around. So little bit of problem, nobody really will notice it. And he's not going to complain it also until and unless the carer gets affected. So today mine is, okay, normal changes. It just passes off as normal change. My worry is here, mild cognitive impairment. Are we able to pick up mild cognitive impairment? So how is it that we make it a habit and a practice to assess mild cognitive impairment? So, there are certain things which we can do, like an immediate recall, a word finding, complex problems. So I guess these should be put into practice. Anybody coming to us with any of the risk factors, general practitioners, especially here, pharmacology students, anyone who has a risk factor, make it a point to address whether they have a mild cognitive impairment. So once it is dementia, it's, you are there, and then lot of work has been done in that area. So I'm not going to go into that. So let's see how we we go ahead and we get that warning sign. We think normal aging will say slow to think, but then not normal aging is I can't think the same. Okay, I can't think the same. Slower to do, fine, but he'll say I'm not able to do it like before. So he says I can't think the same. See, I could remember 10 numbers, but I can't think the same way that I was judging. So judgment here, he's slow to do, but here he'll say I can't do like I was doing it before. Normal aging, he hesitates, but somebody who is having early cognition impairment, he can't get started at all. There's kind of a hold back for him. He can't get started. So normal aging, he'll say, okay, look before, he's cautious. He knows he will be careful. But early dementia, he does not seem to move. He cannot move. And in normal aging, maybe he knows the person, but he cannot, the name he can't this thing. But here sometimes he can't place the person at all. He says, I have seen him somewhere. Where have I seen this person? He looks familiar to me. It does not happen with family people, but somebody he kind of knew very well before, but he's not able to place that person. Okay. Then in normal aging, he may pause to find words, but early use of inappropriate wordings is, it's not a normal aging. Now he goes to the past, but in when he's in early dementia, he gets confused about past versus new. He says, no, yesterday we went there, isn't it? Then the family says, no, we went it long back. Oh, yeah, we went long back. So there is this subtle crossover that happens from normal aging to not so normal aging. And this is where we need to, I feel that every younger person who's looking after a little older has to be sort of trained, to catch this early and bring them early. Of course, there's a lot of genetic work going on in late onset. There are alleles. Maybe we should do genetic study in families who are having Alzheimer's, their children, pick it up early and see whether we can, do some, preventive measures, neurogenesis, all that. Early onset, of course, we all know mutations of chromosomes and Down syndrome. A lot of things have been identified in genetic. Now, when I talk about pathological changes, there are pathological changes. So remember one thing, this whole cognition is of the brain. So I can't cut open the brain and I can't see what's really happening. Is amyloid getting deposited or not there? Okay, at 50 years, I'm going to cut open a piece of the brain and I'm going to do pathology. I'm not able to see. But actually what happens is there's aggregates of tau, there's aggregates of this, there's aggregates of amyloid-rich plaques, there is neurofibrillary tangles, there is neuronal degeneration, there will be Lewy body deposition. So these are the pathological changes that is having, that's happening in this person's brain. And added to that, there's a lot of chemical change also. So they are saying now there could be excessive amount of certain trace elements like copper, zinc levels in the brain, we did a study of homocysteine, B12 and cognition. And we did find that increased level of homocysteine does affect cognition, and we compared with an MRI. This was a study by, I didn't put the study here, I should have put, we have published that paper also. We compared it with MRI. It was one of the thesis topic of our postgraduate students, and we found very interesting finding in this study. And therefore, I think homocysteine level, can this be a marker? Of course, our study was small. We did not get any statistical significance. But I think this is where we need to go. Maybe check, look at these trace elements. If somebody has more of copper, look properly into imaging and then, pull out those people and do their cognition assessment. There is structural change, as I said, there's significant. So you will see one thing very common. You send an MRI, you suspect stroke. So you send an MRI, they'll send us back saying age-related cerebral atrophy. So this will be the diagnosis of either an MRI or a CT brain. Now, I think we can work with the radiologist. Okay, you're saying age-related cerebral atrophy. Can you give me more information on that? Is it mild? Is it moderate? Is it severe? Can you by imaging tell me that, can I help this person? Call that person back. We think when we get that age-related stuff, we don't even look at it as important. For me, if there is a, infarct or a hemorrhage, now that makes me sit up. But we never give importance when an MRI report comes to me and says age-related cerebral atrophy. In fact, these are the MRI we need to stand up. Are these the cohort that going to develop dementia in the later part? A 65-year-old, 55-year-old, why should he have cerebral atrophy, age-related? So that is the question we need to ask. So when a brain, of course, abilities will be lost. And of course, hello, somebody's mic is on. So it's experience and it's individual based. So look at the brain and look what happens to the brain cells. So you can have mild to moderate and you can have severe. So in a mild to moderate, you can have some bit of cortical shrinkage. You can have shrinkage of the hippocampus. The ventricles will be more. In fact, when we get these MRIs, ventricle size is not mentioned to us unless and until it is so gross, it's pressing on the structure and you have an NPH. But I think these are the MRIs. We have to go back to radiologists, tell them, look, I'm interested here, and get the patients out, see their cognitive ability, and then put remedial measures right here when there is mild to moderate enlargement of the ventricles. When it goes to extreme, now if I get the extreme, it's not going to matter to me at all. So this is where I think imaging can help us a lot. So pick up early in imaging. And therefore, when the amyloid is so much deposited, or Lewy body deposition, and I get to know of it, it's not going to help me too much at that level. So there are a lot of, I'm just asking, picking up early. I don't know how many radiologists are here, but I think if we have to pick it up early, we need a whole lot of radiologists getting trained in dementia, getting trained in Alzheimer's and allied disorders, so that they are sensitive to pick this early. I have never seen a radiologist really get interested in dementia. There are a lot of things that they can do and help us who are working with dementia and population to pick it early. For example, PET scan can really tell us early dementia, late. These large studies they will do, and it gets published and gets forgotten. But I think these are such lovely, interesting studies. It should come into day-to-day protocols and practices. So I think maybe the radiology, imaging, so first I said, pick it up early. All practitioners should have a keen eye to see cognition impairment. Next, do I have patients with risk factors? How do I check it? Next, I'm pushing to imaging, because pathology, I can't cut brain and then look at it. Then I said chemical. So we need to look at biochemistry people, whether they are interested and how they can help us with this. And then look at radiologists who can help us pick these things very early, because they can tell us that there's going to be, they link up. So we need to have a comprehensive team to manage pick it up early dementia. That should be the sort of motto and of the future, and make a comprehensive with all these people in the team. So we have 10 forms of dementia. I'm not going to go to it because Dr. Diaz will be talking to you about it. Okay, so he will deal with it. Mine is just mild dementia. Okay, able to function. Now, whenever there happens, now there's a thing here, able to function independently. Now, none of the physicians really check the Barthel score or ADL scores. Now, nobody will ask, now, is he able to button his shirt? Does he do his work as before? So we pick up mild dementia. They come for check of blood sugar, but we never ask them functional ability. Functional ability is one of the executive function which indirectly tells me, look, he's forgetting something. There's some problem with it. I can pick up Parkinson's early. I can pick up dementia early. I can pick up depression early if I'm asking about his functioning independently. So that's very, very important. Now, confusion and lapse of judgment, they come. But The subtle lapse of judgment or a subtle confusion is what we need to separate, which I've already clarified and told you earlier. What is the difference between normal aging and that subtle loss of confusion and subtle loss of forgetfulness? Only the physicians, cardiologists, they can help us to get these patients to us. Or I think we should go to all these corporate forums and everything, educate them, all the people who are about to get retired, 60, and maybe give talks. I'm not very sure how we are going to do it. So although early common signs are there, memory loss will be there, increased confusion, reduced concentration. Yeah, but one point I'm going to pull you on. It is emotional liability and fall. We never ask a patient, do you fall? Have you fallen? If a patient is repeatedly falling, that's an early indicator of dementia. Look at his ventricles, look at his cortical size. It's so important. The patient fall, he goes to orthopedics if he's fractured, they go home, then they fall again, then they go to the next orthopedics. But when it goes to orthopedics, nobody will do his cognitive assessment. He's come twice to me with a fall. Should I do an MRI? Is there anything wrong with him? Is there a cognition problem? Nobody sees that. Of course, repeated fall can even warn cardiac. There's many causes of repeated falls, like cardiac. We'll pick all those. Cardiac, like complete heart block. We will pick them. But dementia, repeated falling being a warning sign of cognitive decline, we don't pick that up. Emotional, we have patients who come to my OPD, and if I ask anything, they cry. So repeated crying again is a warning sign. Of course, it points more towards vascular dementia, pseudobulbar palsy, Parkinson's, but also it could be, an early sign, and kind of apathy, withdrawal. So these also you have, and next important is behavioral changes. He was not like this, he has changed. So he was not like this, he's getting irritable these days. I have seen wives complaining. See, before he would not shout, he's shouting now. Many husbands complain. Before she was not shouting, but now she's, snapping at everything. Now, these are signs where you have to pick them, that subtle change in personalities, cognitive decline has to be seen. Okay. So warning signs again are delirium being early, memory, it's not new old, early signs, subtle, misremembering, and if we don't pick up, they can get worse and they can kill. So watch for patterns, watch change in routine, forgetting names. This is for all the carers, your elderly, what does he ask repeated questions? You get irritated with that. He asks, what time are you coming? I'm coming to her. After 5 minutes, what time are you coming? So if somebody in your home is asking you one question repeatedly, that means it's a warning. Okay, so pick it up early. Suddenly, a person was sleeping, he can't sleep. He says, I don't know why these days I can't sleep at all. So what we do normally, we put one NSAID or we put one Zolfresh. But again, changing in sleep pattern is very, very, a person who is usually tidy becomes messy. Because, cognition, so he would have been so tidy, then he'll say, you were so tidy before, what has happened to you? They suddenly become messy. Okay, so these are the things which you need to pick up early. So 10 early signs of dementia I have written here. So all this suddenly that happens to them, mood change, little difficulty in problem solving, little withdrawal. He used to talk earlier. Again, elderly people get withdrawn, go into depression because deafness worsens very rapidly. So that's another area we don't look at all, is hearing. They lose hearing. Nobody will ask them also, can you hear properly? Nobody asks, and they feel shy to put the hearing aid. So they can develop language problem, communication because of deafness also. So you have to ask them, can you hear me? Hearing is fine. He's developed early language communication. Your antennas should go up immediately. So that's important. Now I'm going to go brief into tools. So we have certain tools and techniques that we do. Very briefly, any physician can do it. We call it as clock drawing test. So you just draw a clock and ask the person, can you show me 4? Can you show me 3? Find whether he can do. That's a simple thing we can do. Now people come from village. Now it's very difficult for a villagers. Okay, you draw a clock. St. John's has come with a very nice thing. You keep on Rangoli box with you. So you ask them to make a nice, you draw it and then say you do with the Rangoli, because they're deft with Rangoli. So village women, I could put the Rangoli before, but now she forgets the pattern. Now that's a quick catch. Instead of CTD, you can do that. Okay. And then mini cog. For example, you tell them 3 things. I'm going to go further. Mini cog, that is the recall and register. The very brief, you can finish it off in 5 minutes, 5 to 6 minutes, which will warn you, oh, there is something wrong. I have to send it to people who know in depth about it. Okay, that's very important. Now, brief, yes, we go to the next step. We geriatricians normally do that. It is also general practitioner's cognitive assessment, where it's about 10 minutes. You can check memory, language, visuospatial, executive function, other daily. So this takes about 8 to 10 minutes, the brief. And you can do the MOCA. So there where you check the orientation, memory, language, attention. I'm not going to show you this because all these tools are available for you on the net. You have your Google Mama, Yahoo Chickappa, and other Chickamas. It's all available there. You pull it out. I'm giving you the names. So how to do it, everything they very nicely tell you, but nobody knows what the names of it and where to get it from. So usually this, if very brief, there's an issue, you do the brief. So if there is, you go extend to language and attention and bit more on daily activities, you extend. Then you go to detail. They have a problem in very brief. You do brief, they have scores, there is a problem there. Then you do a detailed assessment in, these 3 are there. We call it as ACRR, IQ code, and the recent, updated mini mental scale, which are in depth. And these normally people like Dr. Murali Krishna and others who, Dr. Dias, who deal with dementia, they go into detailed tools of this and they will assess the individual. But normally patient come here to them. It is our duty that we do very brief, which is 5 minutes, and then we do the brief if it is possible, so that we pick it up early and give them to work on the patient. So this is 3 validated assessment tools are there, which you can use. GPCOG is called as General Practitioner's Assessment Toolkit, and MI is Memory Impairment Screening, and MiniCOG is Mini Mental Cognitive Assessment. So this is very, very important. And IQ code is, that is a carer who gives his answers based on what he sees of the patient. So that is for patient tool. So we have patient tool and patient assessment toolkit. So assessment will be done by us, but you can give it to informant, the relatives, this IQ code, and they will tell you what has happened. Suppose you pick up very brief, you can give this IQ code to the patient's carer and say, just can you observe him in the house and come back to me? So they'll observe them for a week. So they come back to you with a pattern that is happening in elderly. So that will be very, very good. So you can use these validated tools in your clinic. So let me take a bit about cognitive impairment. So when we talk about this orientation, you can ask year, season, but in a village person, you should know to adapt. If he comes to, you can ask him, Ivaga yav in Kannada, his language, masa, ati masa, nei masa na male, they should be able to tell. And then the month, they go with their Kannada. So you should be well versed that which community. Normally, why we don't do cognition is, there is no validated tool for local. You have to develop your own innovative ways or talking to rural people and your background areas. So then you can ask, from where are you coming? Quickly you can ask. His orientation. This is very, very subtle and very important. There was a patient called Dodegowda who used to come to us regularly, and he used to come BP plus, BP pressure, and sometimes admitted up and down fluctuation. One fine day, usually the son used to be there, and this man used to smile. So one day what happened, the son had gone somewhere. So I asked him, what's your son's name? Where's your son gone? He smiled at me. And then I thought, this is odd. I said, where's your son? He smiled at me again. And then when his son came, I said, who is he? He smiled. And then he saw his son and said, he is the one who does lots of things for me. It is then we caught that the Degowda was going in for memory impairment. And it was a very sad time because the children loved him. When the son came to know he's forgotten his name, the son wept crying. Because it was too late at that point of time. The Degowda had didn't know his son's name at all. He knew he was somebody very important to him, and he was clung on to the son's hand, but he had forgotten the son's name. So every time you can just quickly ask their orientation. Who are your children? Just like a chat. They'll also feel happy you're asking about children. Registration, you ask for 3 objects. 1 second, any objects you can say which he is familiar. Now, if you tell a villager, tell me clock, aeroplane, he may not know. So in Kannada, you pick up 3 words that, he's gadde, tota, something like that. He should register. He's registered means what? He's able to register frontal lobe and he's able to hear properly. Sometimes you say, and they'll say, huh, and he cannot recall. You'll say, okay, patient is demented, not recalling. Why? Because he's not able to hear. So you make sure he's able to hear and then ask and then begin his attention. Now, I can't ask a village person 100 minus 700. You ask me, I may not in myself be able to answer. So here calculation can ask. So they may be, you should be able to go into their level for attention and calculation. And word backwards, anything you say, maybe you'll be able to say it backwards. And then after that, you ask him, I told you 3 things, can you recall? Now, when you do this, remember, it should be a silent environment. You cannot put it in a noisy where he can't hear. You are shouting, he's shouting, there's noise in a quiet room. So recall less than 2, even if he recalls 2 and he forgets 1, that is an early sign. Not when he forgets all 3. Even if he cannot recall 1, it is important. Then we ask them to draw some complicated thing like this, whether he's able to follow. So there's a problem here in recalling, registering. I do this. Here I said you can use Rangoli or, the farmers do some other thing. You can ask them to do their complicated, whether he's able to do. Now, this is the clock. You can ask them to draw a clock and say put time. And then, you does everything normal. 1 is mildly abnormal and 2 is really abnormal. I have seen people who will put 1 some corner of the sheet, 3 in some other corner of the sheet, somewhere there. It's unbelievable. I had a patient who came to me very early, and clock drawing, he took time to figure out, but at the end of it, his 12 was fine, his 3, but the area was okay. Then he took time. He did correct, but he took time. That was my early warning. I had warned the people, look, there is a problem over here. He has an issue. He recalled only 1 of the 3. Clock drawing was not very, very, perfect. So I said, keep a watch on him. And as I said, it's about 8 years now. They went early, exercise. He's holding on. So it's very important that we pick up early. Sometimes village people, you can just ask animals because they may not know other things. You put a picture of animals, ask them to name animals, how fluent they are. Maybe they must be able to tell the regular animal. Now you can't say, yak and things like that, which they don't see. Look, the familiar animals that they see, ask them to name it. They should be able to recollect the name of the animals. These are things which you can very simple do. Another thing which nobody does is get up and walk. We all should do this fall risk. Ask the patient, look, get up, walk, and come back and sit down. Any patient who when they walk in, you see that somebody's holding or he's walking slow. He has a slight imbalance or he has a little antalgic. So here I always love Sherlock Holmes. Sherlock Holmes came out by Dr. Dr. Watson, his professor, who had this uncanny knack of diagnosing by just observing when a patient walks in, and he created this character of Sherlock Holmes who just sees things. So I think, when you watch a person entering your room, how does he come in? Tells you a lot. He comes with blank, he's a little scared coming in. That means there's some cognition. He's not confident of himself. He's a little slow. Such patients, you should take them to a side and figure it out. So observing a patient as he walks in is the first step to pick it early. So you do this for Paul. Ask them, get up, go walk, come back. If he does it confidently, fine. Can't get started, can't get moved. He goes slowly. You can even pick up early Parkinson's with this fall risk, and then you score it. So you do assessing, clinical observation. Some are self-reported response. Yes and no. If it's yes, you quickly do a brief assessment. You do mini cog. Then you give the patient 1 questionnaire and say, go do it. The general practitioner from whom they have come, send them also. And then trigger concerns. You go in depth. So this is the way. So we should be here, pick it early and not allow them to go into late. I have put a case here. I want all students to see this case and they will send their answers to Dr. Joshi. And the best answer will get a prize. I want the students to read it. An elderly with diabetes and hypertension comes to your clinic for checkup. Of late, patient sugars and blood pressures are going in two ends of spectrum of hypo and hyper. Carer is irritable with repeated visits to doctors. So I want you to work on this. Next, Mr. G, a 75-year-old retired car salesman who was first seen in clinic in May 1998, said he had lost interest, everything. I don't want to play golf. I've lost my sense of direction. I don't have the energy. He was sleeping more and prolonged daytime naps, just feeling lost. So I have given you two. Kindly take a picture in your mobile or whatever, screenshot, and I want you all to work on these two cases. I'm giving you 2 minutes to take a photograph. Maybe if you have time, we can discuss, but take it. So let me go to the next. So we can prevent dementia if we pick it up early. You know, sad to say that the 2 years of lockdown, so many elderly have deteriorated cognitively. They have become depressed. Their thinking has gone down. The little bit that they used to explore a new shop, a new thing, go to some new vegetable shop, pick up some vegetable, it helps their cognition so much. The children got so scared that they tied up their parents in the house, did not even allow them to go out. They have declined cognition. I've been telling Dr. Joshi, let's do a study of community elderly cognition assessment in the last 2 years of lockdown. So you need elderly to have their own small activities, a little bit of exercise to prevent dementia. Diet is one thing completely neglected in any form, other than saying don't eat sugar for diabetes, cut down fat, I'm looking at cholesterol. But we never think of a healthy diet. Now, what happens to elderly? Either their teeth are weak or everybody pulls off their teeth and then they don't eat. And then you will see they get brand new dentures. But after 6 months, their thinking would have gone down, cognition would have gone down, memory impaired, and they would have lost tremendous weight. They would have become frail. But I've got a new denture, and the denture doesn't fit because he has lost weight in 6 months of removing the whole teeth. So do we really advise a healthy diet? Do we have a pattern for a diet for elderly? If I give a sheet, and which I got out from some textbook, how is he going to adapt to this diet? So diet planning in elderly is very important. They have vitamins, they have protein, some nutritious food for energy building, memory building is important. And spirituality, we get confused with ritualism. Ritualism stresses the elderly more. So spirituality is of a different kind. It's very positive. It's very helpful. So we have to have a group where we bring in spirituality, going unwinding themselves. I think our one of the GSS Yoga Center, Vatsalya, they're doing a lot of wonderful work. This is where you can prevent a patient early dementia from they can recover. And sleep, and sufficient sleep is very, very important, especially. So these are the 4 which I think 30s, 40s students, this is for y'all also, because all these 4 y'all don't do now. So if I develop dementia at 80, you're going to develop dementia at 45, 50. So please do all this in a proper way. So exercise gives health benefits. It improves mood, better sleep, and reduces likelihood of constipation. And with exercise, motor skills are maintained. It's not that you do weightlifting and extra. Very slow exercises are very important. It also reduces falls and improved. Manglo page as well as their centers are doing wonderful work. They've started this group called as Yen. So we have all joined. I too have joined. I'm 63, by the way. And they teach us exercise. I walk, but I joined this. Believe me, it has rejuvenated me so much, because we need to tap the talent of the youth. And there has to be a connection between the youth and the elderly if we have to pick up dementia early and prevent it. They have to teach us lots of things that keeps us youth and happy. And also disease associated. Yeah, you have to control blood sugar, blood pressure. But I have seen, that is not the only goal. The elderly get so obsessed with their sugar level, the BP, 10 drugs, 15 drugs. That itself can cause cognition problem, the drug interactions and fluctuation of blood sugar. So there should be a certain, you have to control blood sugar. You can't leave 500, blood pressure 200, but then it should be controlled in a very stable manner, not get completely preoccupied that my life revolves around blood pressure and diabetes, not like that. And so it improves behavior and also communication and social skills. So we need to go to hiccups, learning will, stress will decrease. When you do all that, the main area is hippocampus. So good diet, good nutrition can pick it up early declining, put these people on it. It will definitely develop development of hippocampus, and it will halt or delay in memory. Calorie restriction is definitely helpful, but nowadays we see a lot of calorie foods only, burgers, pizzas. I'm not against any type of food, but too much of it, calorie, definitely affects memory. More of omega-3 fatty acids, that's good. Now they say nutrition, all flavonoids, definitely it helps in neurogenesis of the hippocampus. Go ahead with it. They say blueberries, we have lots of berries over here, eat a lot of berries. Now they're also saying soft diet is bad. You need to chew for improvement of your memory. And good sleep. Most of 40-50s, we sit late with our laptops, is going to really affect our memory in days to come. So that's very difficult. So we need, so whenever we pick it up early, build activities, we need to get active, socialize, de-stress, get sleep, control our blood pressure and diabetes, but take medications very carefully, and pick up the risk factors early and work on it. This is very important, that these are risks. When I'm seeing diabetes, I should not think only, okay, this is going to affect kidney, liver, lung, this, that. It's going to affect his cognition. I think Dr. Baswan Gaudappa did a wonderful study of diabetes and cognitive impairment. And Prabha did a wonderful study that you over-control the blood pressure. Those patients definitely had cognitive impairment and memory impairment. So you need to control, but in a very nice way. And family involvement is important, and you learn new things. That's very necessary. So you can learn new language, new flute. Don't feel shy. I'm 70. What I have to learn now? That is the age to start learning new things, to halt dementia. And if it's early dementia, you can stay there by starting to learn new things. So at the end, dementia is brain failure. It's got a big umbrella. Dr. Dias will see you. And you have to have a good evaluation after screening. Just screen and live is not enough. Identify early, plan, and avoid later major problems. So I have finished my talk, and thank you very much for a patient listening, and questions, I'll be happy. Thank you. Or we can take it after Dias's lecture. Dr. Dias.
Thank you, ma'am, for the wonderful and interactive talk. Now, if there are any questions by the delegates, they can
Dr. Dias, or one or two questions. I can see very enthusiastic couple, Usha Subramaniam there. You have to unmute, madam. Unmute yourself. No, you have to unmute. You press on that unmute.
Is it okay?
Hello.
Hello. Nice, doctor. Very nicely. We enjoyed your talk.
Thank you, madam.
So many things also. Dr. Amit Dias has never missed me any chance like that it is. So I'm very thankful to Doctor, you and Amit Dias and the full entire group. And we wanted to make this year challenge. Dr. Amit Dias told us. So we wanted to make it a successful program, madam. Thank you very much. Thank you.
We can have Dr. Amit Dias, and then we can take questions, because already I've crossed 4. Ma'am, if the elderly is able to recollect, say, a prayer or a poem, but speed is slow, is that? Yes, If the speed goes down also, you have to find out why the speed is slow. See, these are early signs to pick up. So you should not wait till he forgets the whole poem. Now that is late. So pick it early, and it is with us physicians. We should pick up early so that people like Dr. Amit can work on them earlier and restore, whatever they have sustained. So when we talk about memory, it's all about sustaining where you pick them. That's important. As I said, slowing down is necessary, and get confused. Okay, Dr. Amit?
Sure.
And I want the students to take those two cases that anybody can take and then work on that.
Thank you very much, ma'am.
That's the way cases come to physicians. And, and then it should start there.
Thank you very much, ma'am. Now it is time for the second talk, which will be delivered by Dr. Amit Dayas. He will be delivering a talk on dementia, what everyone needs to know. Dr. Amit Dayas is an assistant professor in Department of Preventive and Social Medicine at Goa Medical College. He is also the founder secretary of Dementia Society of Goa. Dr. Amit is an epidemiologist with keen interest in geriatric medicine. He completed his MD at Goa Medical College and pursued his DTM and H and MSc in clinical trials from London School of Tropical Medicine and Hygiene in UK. Dr. Amit has been awarded with many prestigious awards. His research on developing services for families of people with dementia won the prestigious Foundation Mederick Alzheimer's and the Alzheimer's Disease International Prize for being the best evidence-based psychosocial research in 2010, and much more. Now I request Dr. Amit to deliver the talk.
Thank you very much, and thank you for the invitation. And I think Dr. Pereira Pratibha has made it very easy for me because she has covered up most of things that everyone needs to know. And the Alzheimer's Disease International has come up with this theme this year. Can you see my screen?
Yes, sir.
You can see my screen. Yeah. So Alzheimer's Disease International has come up with this theme, no dementia, no Alzheimer's disease. And the reason for this is that they want everyone to know about this condition. That is the first step to be able to pick up this condition early. One needs to know that it exists. One can't be feeling that it doesn't exist. This is something that happens in the West. It cannot happen to us. Everyone needs to know that it happens. It is very common. It is increasing. And unless we know what it is, we will not be able to take the first step. The other reason why we are really interested in giving this talk is it's not enough for the doctors to know. In fact, the problem is that the doctors themselves, the medical fraternity themselves, do not know too much about Alzheimer's disease and dementia. The policy makers themselves do not know about the public health importance of this condition, and therefore we don't see much action in this line. And therefore, it's important for us to get people of various levels aware about this condition. So my talk is going to be very simple. Much of it is going to be an overlap, and I'm going to just stress whatever Dr. Pratibha has actually mentioned very clearly, and also be talking about what Mrs. Subramaniam was talking about, the Move to Prevent Dementia challenge that we're giving out to everybody. And then I can see a lot of students here, very enthusiastic and very patiently looking at the presentation. And I think I would want all of you all to participate in this. So let's try to understand in this small half an hour or so, we'll make it very clear to everybody what is dementia, because if you don't know what is dementia and know what is Alzheimer's disease, we don't get anywhere. We need to know about dementia care. We need to know about prevention, and this is what Dr. Pratibha has mentioned. You need to know what to do if there is a problem like this. You need to know where to seek help. The message that we would want to give everyone is life does not end with a diagnosis of dementia. It is not the end. It's not a death sentence to you. A lot can be done to improve the quality of life of people with dementia, and you need to know where to go for that. And the Alzheimer's and Related Disorder Society of India that Dr. Joshi is one part of and I'm part of, and there are several chapters all throughout this country, has been working for many years now to try to raise awareness about Alzheimer's disease and dementia, to develop services for Alzheimer's disease and dementia, to work together with policymakers to get dementia the attention that it requires, and tell everybody that we can't forget people who cannot remember. We also need to understand the concept, the larger concept, what we call dementia-friendly community. And we can, in our own little way, make our part of the jigsaw friendly, such that together the whole community can become friendly. So what is this all about? Is what this lecture is going to throw light on. And I'll keep a lot of time for to know, so that you know the answers to the questions that that are there in your mind. The first question that I would want to ask you is, why do you want to know about it? The very fact that around 70 people have come for this session, it's because you are a little curious about it and you want to know about it. Why do you want to know about dementia? Anyone would want to put in the chat? Why do you want to know about dementia? Yeah, I'm happy to take questions from you. You should be happy to take questions from me as well. So why do you want to know about dementia? Okay, in the interest of time, I'll just go ahead and say that you would need to know about dementia, one, because you're curious, and it could be that you would have someone around this place who's having this condition. Two, we are raising a lot of awareness about this condition, so there should not be any confusion about it, and rather we should have the clarity on what exactly this is, and not lead to any misinformation about this condition going all around. And mainly, we want you to know about dementia as students, for example, the very young students over here, is because one, you can recognize this among your loved one around you. Two, you can be agents of change. You can be the catalyst, such that through you, other people will get to know more about it. If it stops at 70 people who have come for this session, I think that is not what we aim. We want you to educate other people so that they also know about Alzheimer's disease and dementia, and they also know that life does not end with the diagnosis of dementia, and a lot can be done to improve to help family members of people with dementia and the person with dementia themselves. Now, this is just a picture about this wonderful machine that we have, our human body, various organs. And for example, when we had COVID, we realized the main organ that failed was the lungs. The brain functioned well, the kidneys functioned well, the heart functioned well, but the lungs were not functioning. They were not getting, the body was not getting enough oxygen that it required, and people were dying because of that. Similarly, this is a condition that affects the brain, and the brain has various parts, as Dr. Pratibha mentioned very clearly. There are various functions of various parts of the brain, and depending on which part of the brain is affected, you can end up with that kind of a problem. So whether it's the frontal part of the brain that is affected, or the occipital lobe that's affected, can affect your side. Now, this is a condition that affects somewhere in the temporal lobe, and it affects your ability for language, your comprehension, memory, information retrievals. All these are affected because one part of the brain is affected. So one message that everyone needs to know, that dementia is not a normal part of aging. This is a degenerative disease that is affecting the brain. Just as you get a heart problem, just as you get a lung problem, just as somebody got COVID and is affecting the lung, or just as somebody has a kidney problem, this is a condition that's affecting the brain and causing a problem in people. And it's not a normal part of aging. So if somebody is having these signs, don't just stay there, seek help, and help is available. So let us try to unravel the mysteries of this dementia and try to understand more about this wonderful organ that is our brain. It all started in the early 1900s when a patient called Augusta D had gone to this gentleman. He was a German neuropathologist, and he asked her, "What's your name?" And she said, "Augusta." "And what's your last name?" She couldn't just get that. After a long time, she said, "Augusta." "And what's your husband's name?" She said, "Augusta, I think." So she couldn't just forget. There was loss of memory. But to an extent that she couldn't even remember her own name properly. She couldn't remember the name of her own husband. This patient died, and later on, this doctor, she had donated a brain for research purposes, and under the microscope, they found out some abnormal proteins inside the brain called beta amyloid, which even today we know as we feel is the cause for this problem inside the brain. The doctor's name was World Alzheimer. And after his contribution to this condition, where he has made the diagnosis, the disease is named after him as Alzheimer's disease. And this is a picture of the beta amyloid plaque inside the brain. And as Dr. Pratibha very well showed, there was a time where the only way you could actually see this is a post-mortem. After the person died, you take the brain and look under the microscope and do studies. But now you can tag beta amyloid. We can use PET scans and make a diagnosis much earlier. In fact, people can make a diagnosis of Alzheimer's disease even before the clinical signs come in. So even before that, you can actually tag the beta amyloid and see under the PET scans and see where exactly these deposits are and make this diagnosis. So some of you will be thinking, and is any forgetfulness? Everybody forgets to some extent. You've forgotten where you put your keys, or forgotten where you kept some important documents. But is any forgetfulness dementia? Then does it become a disease? And again, this has been very clearly spoken by the previous speaker. What is the difference between normal aging and Alzheimer's disease, and where you draw that line? The diagnosis is even difficult for medical professionals, even if you go to an expert. Making a diagnosis very, very earlier on, there's a suspicion, and as Dr. Pratibha said, you need to tell the person, come back after 3 months, come back after 6 months, we'll do an analysis again, we'll evaluate you again. And in case there is progression, in case there is worsening, then we will be able to come to a conclusive decision on what exactly is happening to that person. At the same time, you need to investigate for the other problems that the person has. I often give this example. We had these cassette players before. So, you put a cassette inside and you press the play button, and is that disturbance from my computer or is it from somewhere else's sound? I don't know, there's some kind of a hissing sound. So you press the play button once you put the cassette inside, and the play button plays very well, the songs from the cassette would play, but the record button is not playing. So the person cannot remember new things. So that is what's happening in a person with dementia. They cannot remember new things that happen. They can remember the past. Now, this is kind of an oversimplification of what's really happening inside the brain. A brain is like a computer. So I'm giving you this additional example. So on a computer, you have various files. You have files that you have saved, your photographs during your childhood, your important documents, things that you have written, important poems, your movies, some other letters that you have written. So you have various kinds of files on a computer. Some are old files and some are new files. Now, when a person starts getting dementia, it's not only new memories that cannot form, they cannot even process sometimes saved memories. Memories that have been saved, that are there with them, they could remember at one point of time. Now they cannot retrieve these memories. So that is what's happening. One needs to understand, and that is about dementia. It's not only having memory loss, but it's progressive in nature. And as time goes by, new files cannot be retrieved. The person will go back, pushed to the old. They will think their mother and father is still alive. They will be looking out for them. They'll be looking out for the place they lived when they were very, very young. They will speak in a language very fluently, in a language that they had learned much earlier on. So in childhood, the language that they were speaking, that language they'll be much more familiar with. For example, in Goa, during childhood, many of our elderly people were speaking Portuguese. And then later on, they began to speak Konkani. And then now that the grandchildren are talking English, they began to talk in English. And they have learned English. They've learned all these languages. They are multilingual. But if you now speak, after dementia sets, and if you speak to them in English, they find it difficult to communicate. But if you speak to them in Portuguese, they're much better off, and they can understand you better, and they can speak much better. So this is how dementia progresses. The 10 signs of dementia is something that everyone needs to know. And this is there all over, and I'm not kind of repeating all these 10 signs, but things like memory loss and recent memory loss. You forget where you put your keys, but if you don't know what the keys are meant for, then that is something to be worried about. You could be worried, you could be fumbling with, when you write something and you're writing a new spelling, you could make mistakes while writing that, and that could be normal. But simple word, if you're trying to write that, you're trying to write your own name, and you start fumbling, what is the spelling of my middle name? If that is happening, then that could be a sign. And language issues are sometimes something that we pick on quite earlier on. We are not sensitive to this because people with dementia find way of covering it up. So if they cannot find that word, they will cover it up and they laugh about it or make a joke about it, and they can cover up the initial stages of dementia. Therefore, it tends to be missed. And therefore, we are having awareness programs like this. So if you notice language problems in people cannot get the word that they're really trying to say, they find problem. They have they're disoriented in time and place. We can get lost in new places, but a person with dementia.
Can't hear him. Dr.
Maybe
Joshi,
maybe he's facing some technical issues, madam. We'll wait for a minute.
okay.
Dr. Amit, can you hear us? Okay, meanwhile, there is a question, madam.
Yeah, and they have to ask. You tell the students, because the person who even asks a question will get a thing.
Yeah. So before the students can come in, there is one question from Miss Jacinta.
Okay.
Madam, if the elderly is able to recollect, say, a prayer or poem, but speed is slow, is that also an indication of
yes,
dementia?
because they're trying to remember the words. So, which they knew, which they could recite. So it's not coming easily, and then they may put in words. So that when anything slows down, especially in language. See, prayer is a language coming out of a memory cell. So I'm reciting this. So that's a warning. Any other students?
Ma'am, there is one more question from Bala Artsy, Hyderabad. I quote, I want to know how I can make a difference for PLWD and their carers.
I think they can join as volunteers, and if they know something, they can teach. In fact, you know what? There's a lady who goes to these all the home for the aged. I would prefer to call it as community living. So there are about 8 or 10 in Mysore. So she has kept one community living per day. So she goes to each place. She's a singer. So she goes to each room. She sings bhajans and she interacts with them. And some of them are so happy, more than the doctor coming, they wait for her to come. And it makes them so happy. They said, we wait for her to come. That, it makes me so happy. So I think you can do that if you can, or if you are okay, then take them out somewhere. And maybe they want to learn, they want to go somewhere which they have not gone for a long time. You can go, you have computer very well, or a mobile, and you can teach them new things. So there are lots of things you can do, instead of some people just come and sympathize. You forgot memory. So sad. I think one thing you should never do is, you should never say, distract them from their worries and bring in new things. There are lots of things. You can start up a volunteer group. Here there is something called as Vatsalya. You can start your own group called as say active aging, healthy aging, some name you can keep, So you can do lots of things. You can form a group, you can visit home for the aged, you can do lots of things.
Yeah, I think Amit is back now. Yeah, we can go for another question. What all it is there?
Anybody, student, they have to ask. Students have to ask. I want to ask students, are they there, students? They can put it in the chat box, and then I will know that attentiveness. Now, Dr. Dias and me put a kind of similar thing. What are the subtle changes you will pick up in people which will warn you, oh, there is something wrong here? At least some answers in the chat box. Any one or two. If, this is what is going to warn me. This is what is going to warn me. Or they can also put answers to those things we put, case histories. Joshi, ask the students.
There are a few students who are in the conference hall. I think they'll be able to ask the questions at the end, madam.
They can even ask from there, unmute and ask.
Yeah, because the students are in a group, they'll be writing their questions in a paper, and
Okay.
one will ask.
Then they
And
can.
meanwhile, we have Dr. Amit who has joined now.
Is
Amit?
join? Okay.
All yours now.
They can put it in the chat box.
Yes.
Yeah, sorry for that, got disconnected, internet problems. Yeah, so we are talking about the 10 warning signs of dementia. Everyone should be familiar with these things and understand that it starts off mild, it then progresses to something more severe, into the moderate phase, and then into the last stage, which is the severe stage. And this is again for research purposes, they've divided this into mild, moderate, and severe, but it's not like there are 3 categories for people with dementia. There can be changes in mood and behavior. There can be withdrawal from any work. And this is again is an important sign. Sometimes there are grandparents who are looking after grandchildren, but suddenly now they don't want to do that. They don't say that they're they're forgetful. I remember a grandparent once kept the grandchild on one of the parapets, which was like, you have these old Goan houses and have some parapets all around the compound wall. Like they kept the grandchildren there and then turned and then forgot that the grandchild was there. And when the parents saw that, they were saying, okay, how can you be so irresponsible? And it leads to a lot of confusion, especially the family members in the early stages do not know what's happening. They feel that the person is doing it on purpose. It leads to a lot of problems and a lot of aggression. Another point that everyone needs to understand is can you hear me?
Yes, sir. Yes, sir.
Okay, great. Excellent. So the point that you need to understand when you want to know about dementia is once you met one person with dementia, you have met one person with dementia. So no 2 people with dementia are alike. It depends on the environment. It depends on the intrinsic capacity of that individual. Depends on the extrinsic, environment of that individual. It depends on the type of care the person is getting, the age of that individual, and the type of dementia that the person is having. Because not 2 people with dementia are same. So it's not that you've seen one and you've seen everybody with dementia. And what kind of behavioral problems they would have, what kind of activities of daily living they would be affected. It all depends. There is a pattern, but it may not be the same from one person to the other. And you can have one person who could be very aggressive and the other person may not be so aggressive. And the moods could be totally different. As Madam was rightly saying, dementia is this umbrella. And very often we get confused and we ourselves sometimes use the 2 terms, Alzheimer's disease and dementia, interchangeably. So dementia is this broad umbrella, which has various kinds of condition under that. I often give this example that it's like fever. And fever is not a disease by itself. No, that's fever. There could be various reasons for fever. You could have malaria or tuberculosis or COVID that is causing fever. Various reasons, typhoid could be causing fever. So just like that, you have a condition where people tend to forget, which is dementia. Dementia comes from a French word called demens, which is out of mind. Philippe Pinel is somebody who had first coined this terminology. And some of the major causes of it. I would have liked to put this slide and say, okay, very few causes are irreversible. That's not the fact. Most of the causes of dementia are unfortunately irreversible. So there is no cure as of now. Disease modifying drugs also are not the best that we could have expected. And there is no kind of vaccine for that. Alzheimer's disease is one of the most common form of dementias. Almost around 50 to 60% of the types of dementias are due to Alzheimer's disease. Vascular dementia is when you have less blood supply. It's like a stroke, and the stroke happens in the part of the brain that deals with memory. Then you end up having vascular dementia. In a country like India, where you have high proportions of people having diabetes and hypertension and high cholesterol, the proportion of vascular dementia is much higher than what's given here. It will be around 20 to 25%. And we see a lot of mixed form of dementias, people with vascular dementia and Alzheimer's kind of dementia. You have another form of dementia, which is called the Lewy body dementia. And in this, people presents with Parkinson's-like features. They will have hallucinations, the Lewy bodies inside the brain, which is causing that. And they tend to have a lot of falls, and they tend to be a lot more having problems with aggression, and behavioral problems are much higher in people with Lewy body dementia. It's a little more difficult to deal with in people with Lewy body dementia. You also have the big 4 are Alzheimer's, Lewy body dementia, vascular dementia, and frontotemporal dementia. Around 5% or 5 to 10% of the dementia is due to frontotemporal dementia is affecting the frontal lobe and the temporal lobe of the brain, that this deals with your personality, and a lot of personality changes tend to take place in frontotemporal dementias. And people with frontotemporal dementias tend to get it much earlier on. So it's not like, usually Alzheimer's at the age of 60, 65, 70, 80, that is when you end up getting Alzheimer's disease and dementia. But frontotemporal dementias can take place even earlier on at the age of 40, for example, affecting them at the prime of their life. And we know a lot of people who have this thing. And it affects the whole family because that's the time, they are just, they are very active. Now, though I say that most of the dementias are irreversible, there are dementias that are reversible, and Madam has covered these up, and one needs to understand that's the reason why you need to go and see a doctor. So you need to see a doctor because if you're dealing with a reversible form of dementia, you want that diagnosis done early, and you want it to be reversed. You don't want to be going through the whole process of dementia and taking care of a person with dementia and dealing with all the problem behaviors when actually that could have been handled, could have been treated in the first place. So there are drugs that can cause dementias. So don't give drugs over the counters. Always talk to the doctor and only take prescribed medications taken by the doctor. When you go to any physician, tell them what medications the person is taking. If you don't give them that information, the doctor may not know and may not be able to relate the drugs to that condition that the person is having. Emotional problems, as Madam has mentioned, there is something called depressive pseudodementia. A person has depression. Because of the depression, there could be cognitive impairment and could have a problem. Metabolic conditions like if the sodium levels are low, that could cause a problem. Endocrine problems, so doing a simple thyroid function test in that individual. If there's hypothyroidism, then the person could be having dementia, could be presenting with cognitive impairment. Nutritional problems, and there could also be normal pressure hydrocephalus that could cause dementias, tumors, traumas, infection, alcohol, autoimmune conditions. So all these can be to quite an extent treated, and so one needs to go and get to a physician. Maybe around 10% of the dementias could fall in this category. I would see a lot more people could have diet-related or nutritional deficiencies that could lead to dementia, and these again can be treated. So you need to go and see a physician. It needs to be investigated, and you need to get help for that individual. Not only for the treatable forms of dementia, even the irreversible dementias can be managed to quite an extent, and we do have medications for that. Now, when we talk about dementias, we usually think in terms of memory problems. So there's memory lapse and decrease in memory, but sometimes memory is not something that even somebody picks up. They pick up the behavioral problems, and that's when the family member would come to you a little moderate to a late stage, where the person is showing behavioral problems. So there are behavioral problems, lack of independence, and as the disease progresses, there comes a stage where you may have to consider a nursing home placement for that individual. Now, nursing homes are not very common, don't commonly take in people with Alzheimer's disease and dementia because the needs for care are much higher up. And there are some homes now who have started doing that, but not a normal nursing home would screen. And in case the person has a lot of needs for care, they may not admit a person with Alzheimer's disease or dementia. So home care tends to be the mainstay as far as our country is concerned when we're talking of huge numbers of people with dementia. And what is fortunate for us is that we do have families, and we do have families who are interested in taking care of their loved ones with this condition. Family systems are breaking up, unfortunately. We are having smaller families. Everyone in the family is working. And so there is no one who, if somebody requires 24-hour care, then there is no one to be staying back home to take care of them. And so there are difficulties. And therefore, we need to build the capacity of families to deal with Alzheimer's disease and dementia. And our work and research in Goa was all about strengthening the families to look after people with dementia. COVID has messed up their lives of people with dementia and senior citizens in general, because a lot, as Madam was saying, are all inside the home. There is no cognitive stimulation. They are worried about what's going to happen next. Family members cannot come and see them. They neglect their medication. They neglect their diet, as a result of which there's a definite decline as far as cognition is concerned. If people had dementia, COVID has by itself caused, there is this brain fog that can happen in COVID, which leads to memory impairment and cognitive decline in people because of COVID directly. But if people had dementia, then they tend to be neglected, even if they get COVID, even the hospitals. And we have seen, putting people with dementia on a ventilator or giving them an oxygen mask becomes very difficult, and people had to cope up with this. It was very difficult time for people with dementia. So let us try to understand what happens inside the brain. And for the benefit of the students, I have a small video that I will show you all. You can just have a look at that and understand what exactly is happening. It's similar to the stuff we have mentioned, but gives you a little more insight into what's happening inside the brain. So I just, for some reason, it's not playing. Is the sound heard?
Yes, sir.
We can hear you. We can hear you. You can go your PPT in slide mode. It's in, we can see the slides on this side. Presentation mode, you can go.
Hello?
Again, he's lost.
You can't hear?
We can see him.
You can't see the video, is it?
The slide is stuck.
No,
Okay,
no, video is not coming. You can go to the next slide.
Okay, I'll go to the presentation again then.
Yeah.
So I think the video y'all could not see. I didn't realize that y'all couldn't see. The video was running. So it was a video on showing what exactly is happening inside the brain. And, this is exactly what happens. There's atrophy of the brain. The ventricles are enlarged. And there are these neurofibrillary tangles that take place. So the neurons get tangled, as a result of which messages do not run from one place to the other. And therefore, new messages cannot be stored. When we're trying to understand the problem of dementia, one needs to understand that though we are talking about a disease, we are dealing with a person. So our care should be person-centered. If you understand the concept of giving person-centered care, the person with dementia is a person. And if you understand that, then a lot of things do fall in place. You have the skills to be able to deal with dementia and deal with the problem behaviors of people with dementia. A lot of things do fall in place. I always talk in terms of the ABCD of dementia. So D is the diagnosis, where you need to make the diagnosis. It is the first step to care. If you see somebody having these memory problems or the signs of dementia, get them to a physician who can make a diagnosis of dementia, get them to a psychiatrist or a geriatrician or a neurologist. So D is the diagnosis. C is the caregiver support. So don't forget the caregiver. If you want the person of dementia to be looked after well, you need to ensure that the caregiver is not burnt out. If the caregiver is stressed, and this is what we often find, by the time they come to you, the caregiver is actually looking after this person with dementia for 3-4 years and already burnt out. It is kind of a thankless job. They don't know what to do. They don't know what is happening. They don't know why their loved one is behaving this way. They're doing so much, and yet the person says you're not doing enough. And sometimes it's getting aggressive with them. So you need to understand what the caregiver is going through and try to address the stress in the caregiver. Besides that, you need to address the cognition. So cognitive stimulation, C is also standing for cognitive stimulation in the person with dementia, because that is something that can help them build this. There's something called concept of neuroplasticity, as Madam has referred to, where you need to try to address this and try to keep the person cognitively stimulated as much as possible. The B is the behavioral problems in people with dementia. So if you train the caregiver on how to deal with the behavioral problems of people with dementia, how to prevent catastrophic behavior, how to see, prevent the behavioral problem from taking place in the first place. Can you see when it happens, when they see a pattern, when is the person having these behavioral problems? Is it when the person is being taken for a shower and the person is given food? So if you understand that, they'll be able to deal and prevent the behavioral problems from taking place. If the behavioral problems do take place, they know how to communicate with the person with dementia and deal with the behavioral problems. And A is assisting people with activities of daily living, because you often see that people with dementia their functional ability is affected, as a result of which they cannot do their day-to-day work. And that's the concept you need to understand very clearly. People often forget, but when the forgetfulness is to such an extent that you cannot do your everyday activity, that is when we say that it may not be normal forgetfulness and it could be a sign of a disease. The other point that everyone needs to know, that it cannot be done by an individual alone. It is not something like malaria. You go to a doctor, prescribe something, you take that medication and everything is over after that. No, it is a long-term process. It's a chronic condition and it involves teamwork. It is about you, it's about the caregiver, it's about the family, it's about the friends, about family who may be abroad. We always, when we have a person with dementia, we try to get the family members, all family members connected. So if there are people abroad, we want them also to understand the condition, and now through various kinds of media and technology, they can get connected and do contribute to the care of a person with dementia. Then there is the medical team, and it's not a medical doctor alone, but the team now that deals with people with dementia. It could be the doctor, the nurse, the occupational therapist, the speech therapist, the physiotherapist. So everyone put together will be the team who will plan out and try to help people with dementia. The problem here is that the medical team is now getting developed. There was a time where we have a shortage as far as since the population is large, we do have a shortage as far as who would be able to provide this care. And therefore, the work that we did tried to show a lot about how we can simplify the interventions for people with dementia, such that even at the primary healthcare setting itself, the primary healthcare doctor can kind of be sensitive to the signs of dementia and refer the people for a diagnosis. And the post-diagnostic support can be given at primary healthcare level itself. And in case something goes wrong, they can identify what these conditions are and refer them to a specialist for specialist care. And also the community at large. That's the concept of the dementia-friendly community. The community at large needs to be sensitive and to be able to help out families with people with dementia. So be very clear about these things. Dementia is definitely not a part of normal aging. People who have dementia do not understand what's going around them. No, they definitely understand what's going around them. And a mistake that we often do is that we feel that people with dementia do not understand what's going around them. They cannot understand what we are saying. And we tend to talk about them in front of them. Or if somebody else has come, see what this person has done. Yesterday, this is what happened. See what I'm going through. I'm suffering so much. This is what we often tend to say by ignoring the fact that the person with dementia can actually understand. They may not be able to respond to what you're saying, but they will at some level process what you're saying and develop a kind of a liking or dislike to the person depending on what the person is saying. A person with dementia is incapable of making decisions. Again, no, and therefore we all sometimes, if you don't involve them in the decision-making process, they may not like that. And that's what leads to, the person was the head of the family, was a CEO of a company, had hundreds of people under him, and he would be telling people what to do. And now you're not even taking his opinion and for any decision that has to be taken. So often, sometimes we tell family to get the person with dementia also involved in the discussion, especially in the early stages. Get them involved in the discussion and decision-making process as well. A person with dementia always leads to aggression. Again, this is not correct. A person with dementia need not always end up with aggressive behavior. And sometimes aggression is a reaction to the situation that the person is put in. Only old people get dementia. Again, this is wrong. And Madam has also mentioned this thing, that even younger people can get dementia. We have a young onset dementia, especially those which are genetically predisposed. People can get dementia much earlier on. Frontotemporal dementias can occur much earlier on. And very often we have this myth that dementia is not common in India. Absolutely no. Dementia is definitely very common in India. In fact, we have more than 4 million people with this condition, and the numbers are increasing rapidly. Now, as I was mentioned before, aggression it is sometimes associated with dementia, but it happens because of various things that the person may be going through. The person with dementia may be having pain, may be frustrated due to something, wants to say something and cannot say it, is sick or having some infection, is scared or threatened whilst doing something, is worried about who's the new person who's taking care, some new physiotherapist who has come, or someone who's giving them a sponge bath they don't know. So these things can be dealt with, and you can help them with very good communication. Communication is key in dealing with people with dementia. As far as the medications are concerned, there are drugs available for even people with dementia of the irreversible type. They deal with, at the level of the synapse where, you have these nerves, one nerve comes and goes to the other nerve. There's a space between them, and there's a neurotransmitter that takes the messages from one nerve fiber to the other nerve fiber, and that's called a neurotransmitter. In Alzheimer's disease, we have seen acetylcholine is a very important neurotransmitter, and this decreases in Alzheimer's disease. So as you know, if a person has Alzheimer's disease, maybe almost 90% of the acetylcholine would go. What we try to do is give a drug called anticholinesterase that tries to keep the little bit of acetylcholine over there, and so the memories can still the acetylcholine can function and memories can still form. So there are drugs that can help, can give them another 2-3 years of good quality life. So therefore, it's very, very important. I'm saying this again, that you need to get a person with dementia to the doctor so that help can be made available to them as quickly as possible. Many people, elderly as such, they would be taking a lot of drugs. Remember that drugs themselves have side effects, so be very careful about this, and I've mentioned that earlier. The other thing that you need to be aware of is that people with dementia may not be able to take their drugs on their own or cannot take the drugs on their own. And therefore, earlier on itself, if somebody could take care of giving them the medications, they could ensure that the medications are taken on time. For example, if you're taking thyroxine for hypothyroid, when it has to be taken at a particular time, when you're going to take your meals, take it regularly. Take the medications, different medications. You don't take double dose of a particular medication and don't miss out on certain medications. So therefore, it's important for someone to take charge of the person with dementia. A key thing that I've said before is that the key to good care is good communication. You can see from these two pictures itself. One is from India, from this, if I'm not mistaken, was from Nightingale's, the picture that's taken by Artsy. And there is another picture here where the caregiver or the person who's taking care is a little more anxious herself when she's dealing with the person with Alzheimer's disease and dementia, and she's making the person with dementia even more anxious and angry. So key is to a good communication is definitely essential. So diminish distraction, converse one-to-one, keep things simple, stick to very short, specific statement. Don't make very long statements because that could be affecting them. If there is any noise in the background, you need to take that off because that could cause distractions. They may not be able to understand what you're trying to say. Avoid argument. Nobody wins in an argument with a person with dementia, so don't just go into that way. Don't try to justify it for the person with Alzheimer's disease or dementia. Just avoid the argument, distract them, take them to another thing. By that time, you should know what are the happy things that the person likes to do and get the person involved in doing these happy things. So just keep talking to the person. Even if the person does not respond, you need to speak to the person because the person could be hearing you and would be understanding that. Understand how you can assist the person in the activities of daily living, which is like grooming and dressing and eating, toileting, sleep, bathing, taking medication, because these are things that the person has to do. And you need to learn various techniques. And through our home care program, we try to train the family members. Or we also have a home care program where we train the maids in the house on how to look after people with dementia by dealing with all these conditions. So once you know the techniques, it's very simple techniques that we have learned from each other, in fact, over the last 20 years, and we share it with other people so that they benefit from that. Deal with the behavioral problems. Something simple like, if a person is wandering, make sure that the main gate is locked so the person does not walk out of the house. And this often happens. Somebody has just gone to have a bath, and next thing they know is that the person with dementia is not there in the house and is walking on the street, and they could be walking long distances and getting lost. And this has happened for other families. You don't want it to happen in your family. Sleep. So we try to get people to follow what is called sleep hygiene, sleep on time, put off the light when they go to sleep. Toileting, ensure that there's a potty next to the patient, or there is the room has an attached bathroom or toilet so that they can go there very easily, or try to encourage them to use adult diapers. Very often this is the struggle, but you can get them to start using adult diapers to make things easier for the caregiver and the person with dementia as well. Feeding, give one food item at a time. It gives soft meals, but now you need to also have something. Be aware of the fact that people need to eat food that was familiar to them, and not some new fast food type of items that they do not connect to and do not like eating that. They may be having denture problems, or they may be having a tooth problem, a toothache, which is causing a problem. So look into these matters. Clothing, encourage them to dress, use Velcro sometimes. Anger diversion, substitution is something that would help. Through the Dementia Society of Goa and the Artsy Goa chapter, now through the Dennis Jarvis Trust and other organizations that are there in Goa, there is Pooj and there is Sangat, and there is a lot of help that is now available for people with dementia in the state. And especially the main focus of care is home care, trying to train family members in taking care of their loved ones with dementia and giving them these simple tips as far as how to take care of people with dementia, trying to address the issues of the caregivers, caring for the caregivers, trying to ensure that they're going and taking the proper medical care and post-diagnostic support. This is a big problem, as I said before, because of the demographic transition that our country is going through, and we'll be soon having a large number of older people. As the healthcare facilities are improving, we are living longer, and the conditions that affect elderly are also on the rise. We have around 50 million people with dementia around the world. This is an estimate by the World Health Organization and Alzheimer's Disease International. But what is more worrisome is that these numbers are set to reach around 152 million by 2050, which is a big number. It's kind of a tsunami that is going to come, and we need to put our processes in place and have the systems in place to deal with this. And one good way forward is to try to see if we can change lifestyle, because there is hope in trying to be able to prevent or postpone around 40% of all the dementias. So if we can postpone that, instead of getting dementia at the age of 60, if we get it at the age of 70, 75, 80, it's still it's a big win as far as an individual is concerned, as far as the quality of life is concerned. We have around 60% of the people with dementia who live in the low and middle income countries like ours and like China. And these numbers are going to rise. If you see the figures, the numbers of people with dementia in the low and middle income countries like ours are rising much more at a much faster rate than the numbers rising in the other developed high income countries. So we need to be aware of that. We already in the last 20 years itself, we have seen a palpable rise in the number of people with dementia, and even in the awareness and the people coming to the health services to take to avail facilities for people with dementia. So dementia, if there are anybody in policy, they need to understand the fact, this is something that WHO has brought out, that dementia is a public health priority, and we cannot ignore this. Just as we take care of people with tuberculosis or malaria and women and children, we need to have a separate department for the elderly and definitely take care of people with Alzheimer's disease and dementia. We now have a national program for the healthcare of the elderly, and dementia is a big part of that. So we need to get this program functional such that through the primary healthcare setting, through the secondary healthcare and tertiary healthcare facilities, we can reach out to those 4 million people and their families to deal with people with dementia. Can dementia be prevented? Yes, definitely we can prevent that. I was part of the Lancet Commission on Prevention of Dementia and also part of the group of the WHO to see for risk reduction for cognitive decline. We came up with this paper last time, and I would urge all of you all to read that. We saw that around 40% of all the dementias can actually be prevented or postpone them by addressing only these 12 risk factors. We need to increase education, but it's not about increasing education in late life. It's trying to increase education in early life, less than 20 years. That is when, if we try to increase education at that time, there are rich dividends later on, we can actually prevent dementia. So therefore, the government's policy on trying to make education for all, free education giving to all children, this is a very good facility. So people need to learn something new, learn multiple languages, and get themselves cognitively stimulated to be able to prevent dementia later on. Physical activity is very, very important. And as Madam has said, the various benefits of physical activity. Again, physical activity earlier on in life is better. It's never too late, but earlier on in life is what makes the greatest impact. Social contact, keeping people connected with other people. And that is what has taken a big blow with this COVID. But still, we can find out various ways. And I'll tell you about what we do in Goa as far as increasing social contact is concerned. Hearing loss. We've seen that people who have hearing loss, the progression towards dementia is much faster. So therefore, if people have a hearing problem, they should be using hearing aid. If people use hearing aid, what happens, the hearing center and the memory center are both in the temporal lobe. So that's what they feel, that there is some kind of a connection there. And hearing itself is a stimulus for you. You hear and then therefore you react. So therefore, you need to make sure that your senses are fine. Because that's going to keep you stimulated and going to keep you prevent dementia. So you need to take care of hearing loss. Hypertension, obesity, smoking, depression, diabetes has to be taken care of. Excessive alcohol intake is known to cause dementia. Head injury and air pollution. Air pollution is also seen to cause heart disease, etc. Air pollution, carbon monoxide, particulate matter are also seen to be causing. In large cohort studies that we have gone through, we have realized that it's also having an impact on Alzheimer's disease and dementia. So understand these risk factors. Age, you cannot do anything about that, but genetic factors also, you cannot do anything about that. Exercise, cholesterol, uncontrolled diabetes and hypertension, improper diet is something that can be addressed, and we can try to prevent head injury to some extent. Besides that, we need to keep in mind the statement, use it or lose it. So we need to keep ourselves cognitively stimulated, and that doesn't mean we need to do something really extraordinary. If you can learn a new language, learn some musical instrument, play chess, do Sudoku, crossword, something that you like, or mainly just go and get involved in some kind of a social gathering, take charge of something, be a leader in a group and get people motivated. Active aging definitely makes a difference. Yoga helps. You can see a lot of students from the yoga school. Yoga definitely helps in multiple ways, because you need to remember the yoga asanas. It helps in improving oxygen. Our brain requires oxygen, our brain requires glucose. If that's what you give the brain is going to give you a good function at the end of it. So pranayam, etc. Simple yoga exercises. Don't get people at the age of 80 to do some complex yoga exercises. Simple yoga exercises, stretch exercises can help. Definitely keep in mind that dementia is preventable. What is good for the heart is good for the brain. And so you need to just do the simple mantra and try to prevent that. We have a program for schools, and that is where Mrs. Subramaniam and others are also involved with. It's called the Mind It program, where we educate school children in trying to adopt a very brain healthy lifestyle. You have others in this group who are from what we call a memory cafe in Goa, which we had started physically before the lockdown. But after the lockdown, we are now doing that on Zoom. And we have various activities for our senior citizens. You can see the pictures over here. They are about activities that we did before the lockdown, but after lockdown as well on Zoom, we have various kinds of activities. Our latest event that we have launched is something called Move to Prevent Dementia. And you can see it on my Facebook page. If you go to my Facebook, we have given out some small, it's on the song called Aiko Aiko. And we have taught a few steps. We want people to follow the same steps because it will help you remember, and you want to follow the same steps. Make a small video of yourself and put it up on Facebook or Instagram, on any social media, to be able to say that you are doing it in order to raise awareness on Alzheimer's disease, and say that by moving, you can actually, by getting this physical activity inside, you're actually trying to prevent dementia, and you're aware of that, and you care for people with dementia, and you care for the cause. So we can be part of that. We've always been, for the last 20 years, we walked on the streets and done various kinds of activities to be able to raise awareness. We had a float on the carnival, and you name it, and we did that. Some music program as well to try to raise awareness on Alzheimer's. So you need to be creative, because majority of people still do not know about Alzheimer's disease and dementia, and therefore the theme is very, very important. And you need to also try to get everyone to do their bit of the jigsaw to be able to build an inclusive society where people with dementia are treated as people of that community, and that community feels that we need to do a little bit more to help the person with dementia live a normal life. They need help. Just as a person with heart disease requires help for the heart, a person with the brain disease requires help to help them remember. They can be given cues. An environment that is friendly for people with dementia will help the person stay cognitively, it will improve the cognition and also improve their quality of life. And we can do it by the existing healthcare systems. I'm not trying to say do something totally different, but try to build the capacity of the existing healthcare system to be able to promote this, to educate people, to reach out to people and build services to deal with people with dementia. We in Goa, the work that was mentioned about was where we trained lay health counselors to be able to do the intervention. So it's like Anganwadi workers, it's like ASHA workers. They could be trained in giving this post-diagnostic support to families of people with dementia. We found that many people with dementia do not come to see a doctor because they find it very difficult to get a person with dementia to see the doctor, or they feel they'll go to the doctor and the doctor will not be able to provide help. So we trained the link workers or the community health workers, the multi-purpose health workers to be able to deliver this package. We also did that recently for another program called DIL in Goa. It stands for depression in late life. It was about prevention of depression in late life and helping elders help themselves by using what is called problem-solving therapy to be able to deal with the problem. It was done in association. This is Professor Charles Reynolds from the University of Pittsburgh, who has collaborated in this study. That besides, we see Dr. Vikram Patel and others who were part of this study. We saw that by training our healthcare workers itself, we can make a big difference in trying to prevent depression. We can actually address the problems of people with dementia. We can improve their quality of life. We can decrease the number of deaths in people with dementia. We can address the issues of caregivers of people with dementia. We can decrease the problem behaviors in people with dementia. So it makes a huge difference by very simple, cost-effective interventions such as these. So I leave you with that, and just leave you with a small quote that one of our members from Narendra, actually from RC, had sent earlier on in our group. And I thought it's a very important one, where we need to come back to the main concept of person-centered care. You need to understand that the person with dementia is a person with dementia and not a disease. So address the person as a person. So my eyes do see, my ears do hear. I am still me. So let's be clear. My memory may fade. My walk may slow. I am me inside. Don't let me go. So you need to know about dementia. You need to know about Alzheimer's disease and reach out and make this whole community of yours more friendly for people with dementia. Thank you very much.
Thank you very much, sir. Now it's time for some questions from our delegates. If they have any, they can type it in the chat box.
Tejaswini is asking about sundowning in dementia. Yeah, so I think that's a very important question. What happens is, I don't know if you're familiar with this terminology, what happens with people with dementia, usually towards the evening time, they tend to have more of these behavioral problems and the memory tends to worsen more. And this is kind of characteristic of people with Alzheimer's disease and also vascular form of dementia, that towards the evening they tend to worsen. So what we tell people is understand this pattern and try to get most of the activities done at a time that they are better off. So if they're better off in the daytime, in the morning time, that is when you will try to get most of the work done with people with dementia, rather than trying to give them a bath in the evening when they have this sundowning pattern. We
Absolutely.
also see,
and I think by evening they should be put in much brighter rooms, with brighter lights, and by evening, and familiar activity being done during that time.
Yes.
So I think that was an excellent observation and question by Dr. Tejaswini.
Yes. Any other questions?
Dr. Dias, I think it was such a pleasure listening to you, and so much of work you have done. And here, for me, I live in the world of elderly. I'm very passionate about elderly. I have a very good team with me, and we have a department of geriatrics in JSS. And I would definitely like to work with you as I'm working with Dr. Hanuman Joshi. So, there's a lot more things we can do in this field. For me, community is very important. I have a social worker in my team, and without a social worker, my OPD will not run. I will not move forward. I need that social worker sitting there. So for me, I put community medicine department as one of the top for any of these, because unless you reach to community, you can't solve this problem sitting behind a tertiary hospital desk. It cannot happen. And I really applaud the yeoman service you're doing and such innovative work. And I definitely would like to work with you.
Thanks, ma'am. Sure. We'll keep in touch. Yeah.
Yes.
I must also thank, I have a wonderful team with me, a very innovative, and I give them the freedom and they come up with brilliant ideas. Where there is Sheldon and
I can see that. I can
Mrs. Subramaniam. Yeah.
I can see that.
They encourage me to do more.
Yeah, I can see that. So, Sakkat Sangata Melia. In one Konkani language.
True.
I have a question. I am Dr. Subramanian. I would like to know how beta amylase is formed.
Yes.
I didn't get that, sorry.
How beta amyloid is formed. Amyloidosis is just a altered pathophysiological changes in the brain that brings out these amyloid tissue. There is no reason why these amyloid form. That is the first chapter we are taught when we join medicine is amyloidosis. It's a kind of a fatty thing which alters, and this amyloid is basically a part of the fat, a fatty, we cannot say exactly fat. It's kind of fat plus chemical changes that happens in the brain, and that deposits. If we knew why amyloidosis happened, it would be very easy for us to prevent so many things. But till now, why the amyloid deposition happens, maybe it is genetically linked or nutrition linked, or chemical, what I said, certain trace elements linked. They still have to go in depth to find out why the beta amyloid deposits there.
Yeah, so I would like to add over here that what we now know, and a lot of people are doing a study on this, because if they say beta amyloid is causing the problem, we might as well find out how it is formed and why it is formed.
Yes,
oxidative stress is one reason why they feel it could be the triggering the formation of beta amyloid. Yes. After a person has a head injury or an accident, for sometimes, beta amyloid is also formed as kind of a protective mechanism over there, but the body knows and how to deal with the beta amyloid. So after it's formed, it's taken off. In Alzheimer's disease, it tends to remain there, and that's what's causing the problem.
Yeah, maybe some genetic link we don't know.
Yes. We also know now the pathway of beta amyloid, how it is forming, and what are the chemicals at different, enzymes at different levels. And we know now that there are various factors. For example, as Madam said, omega-3 fatty acids from fish that you get from fish. They act at one level. Turmeric will act at another level. Green tea acts at another level. So
Pratibha ma'am, you are
yeah, so we now know how
high fatty acids is supposed to increase amyloid. Omega-3 is supposed to decrease amyloid.
Yes, yes.
So lot of work in that.
Yes, lot more research is required in this area.
Actually. Yeah, lot more.
Yeah.
Niranjana Malik madam is there from West Bengal. She is an ardent supporter of ARTSI. Madam, would you like to share a few words?
I was basically a student today. So I was listening to both the doctors, and I was reminded of my understanding of dementia, almost 24 years back. So, sometimes it's just good to sit quiet and listen, and you have ideas that you get from these talks, and you kind of improve yourself. So I really don't have a question, because as a student, like a typical student, I would not question a lot, just listening to my speakers. But it was really very interesting, Dr. Pratibha's speech. I think it was, the whole concept was addressed very differently. She had a very different take. And of course, Amit, I have listened a lot. Absolutely precise, clear, to the point. So thank you. Thanks to both of you. And sometimes, as I said, it's good to sit quiet and listen. So thank you. Thank you so much.
Nilanjana was for 2 decades now, and Nilanjana is a very good friend and doing excellent work herself, not only in West Bengal, but the whole country. She is the person who can be the principal of the school, not a student.
And I'm so thankful to. Yeah, I'm so thankful to have been a part of this, and honor to me to speak on this forum. And Dr. Joshi, I thank you for giving me this opportunity. Thank you.
Always very enthusiastic, Dr. Joshi. Has some program or the other coming up. Is always very happy to see that. Yeah. So wish you all the very best, and thank you very much.
Yeah, as rightly mentioned by Dr. Pratibha and Dr. Amit, see, even though we have drugs for the treatment of these diseases, but the challenges are unlimited, because it's a complex disease. And one beautiful thing I can observe in this webinar today, that some elderly people have joined with a lot of enthusiasm. They have participated. It's a good sign, number one. And in a group, we have to work together. It is not only medicine. It is not only the only doctors. It involves a lot of people. As in one of the very beautiful slide, Amit has mentioned that the family plays a very, very important role. Whatever we are, because of our family only. So with this, we highly thank all the participants, and there are no words to thank Dr. Pratibha and as well as Dr. Amit. We have to work in a team, and of course, Dr. Nilanjana has joined, and Mr. Gopal was there for some time. And thanks to everyone, and especially to our dynamic Vice President, Mr. Ganesh Ji. He has got a small throat infection, so that's why he was hesitant to give the word of thanks. So thank you once again. And before we wind up, we have some plannings in Mysore chapter, and we have got young friends here who have joined today. We have a few programs. Like 18th, we have got a trekking to Chamundi Hills. We call it as Namma Nadage Arogya Dadage. So it's a walk towards better health. We are hopeful that people will join in a good number. And 21st, we have the World Alzheimer's Day. So it will be starting from Kota Anjaneya Swami Temple in Amba Vilas premises to the DC office. And 23rd, we have a workshop in JSS Hospital. Credit goes to Pratibha Madam. We are in the planning stage. So these are a few of the programs we have. Hopefully all will go well. That's what we need, an umbrella. The umbrella is you people, the students, and as well as the supporters of ARTC. So with this, I thank everyone, and thank you, Mr. Anirudh, for an excellent moderation. So we had a small issue regarding moderation today. One of our members was supposed to join, but she had some issues. So thanks for joining in the last moment, Anirudh, and thanks to everyone for the patient hearing. Thank you so much.
Thank you. Thank you. Have a lovely week. Thank you.